educational seminar series. Today's webinar is on the effect of baby-friendly hospital initiative and maternity care practices on breastfeeding outcomes. I think most of you have joined in on one or more of our webinars, but for those who are new to Maternal and Infant Health Canada, MyCan for short, we are a group of doctors, researchers, traditional medicine practitioners from Canada and around the world. We are dedicated to minimizing the burden of maternal and infant mortality using a public health approach, and through working with local healthcare workers, traditional medicine providers, governments, and community members. We have 4 pillars, which include health, education, and clinical skills training, community economic development, innovation, as well as research and accountability. We host these seminars every 2 months. So if you are interested in participating in a seminar or sharing something that you're working on that you're very passionate about, please feel free to contact us and we'll put this up in the chat box so you have it, mycancares@gmail.com. So if anybody wants or has a great idea, feel free to contact us. But why don't we just start and do a little bit of introductions. Our presenter today is Dr. Marie Tarrant. She is both a professor and the director at the University of British Columbia. Dr. Tarrant's program of research focuses on improving maternal and child health outcomes and has resulted in an extensive publication record on a range of subjects, including breastfeeding and maternal and childhood vaccinations. So welcome, Marie. We're very excited to have you on today. Our discussant for the webinar is Dr. Kranti Suresh Vora. Dr. Vora is a professor at the Indian Institute of Public Health, Gandhinagar. Hopefully I said that right. Dr. Vora is an obstetrician who completed a Master's of Public Health at Johns Hopkins Bloomberg School of Public Health and a PhD from the University of Maryland College, USA. And finally, for those of you who have not already had the privilege of meeting her, I would also like to introduce you to the founder and lead of Maternal and Infant Health Canada, professor at the University of British Columbia, and a passionate advocate for health equity, Dr. Farah Shroff.
Hi, everybody.
So as with all of our public webinars, I must add the following disclaimer. You can read the whole thing, but what I will say is this course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. A little bit of housekeeping. If you have questions during the webinar, please don't be shy, put them in the chat box. Some ones, if it's just clarification, we'll answer them straight away. But for the purpose of kind of working smoothly through the webinar, what we'll do is we'll have our speaker do her presentation. We'll have the discussant add in her thoughts. And then after that, we will go through all the questions and have a bit more of an informal discussion at the end if possible, because it's really about building community here. And we have such an incredible community that I just can't wait to hear what everybody has to say as well. So without further ado, why don't we start? Marie, I will pass this on to you.
Okay, thank you. Okay, thank you, Emily, for that introduction, and thank you all for joining the webinar tonight. My name is Marie Tarrant, and whoops, sorry, I'm just making sure I can, there we go. As was said, I'm the professor and director of the School of Nursing at UBC Okanagan campus, and that was our beautiful campus you saw in the background of the first slide. I'm also an honorary professor at the School of Nursing at the University of Hong Kong, where I spent 18 years up until a couple of years ago. So the work I'm going to talk about tonight was actually done at the University of while I was at the University of Hong Kong, and was done in Hong Kong. And so you can see all of my social media contact information here if you would like. So just to give a little outline, I'm just going to go through some general background and introduction. I expect most of you have some familiarity with breastfeeding and things like that, but just to give some basic background so everyone can understand some of the things I'm speaking about. And then just a little bit about the study setting and the research context. I'll go over the study methods, and then I'm going to focus on some work that we've done over 15 years, looking at baby-friendly hospital initiative, hospital practices, and then breastfeeding duration. And we're going to look at some of the changes in baby-friendly practices, the effect that they have on breastfeeding, and then also look at the changes in the overall breastfeeding rates. And then we'll just summarize and have some time for discussion and questions. So I just wanted to give you a picture of the global breastfeeding initiation rates. So these are the rates of any breastfeeding around the world. And you can see that they vary from 99% in Brazil and 98% in the Scandinavian countries. And then we have lower rates in France, 63%, in the US, 73%, and the UK, 75%. And then Japan and China have fairly high rates as well. And this is not meant to reflect all of the rates. There are some countries that have even lower rates, but it's just to give you a little bit of a snapshot of what's going on around the world. And it's actually very hard, even in Canada, to get up-to-date data on breastfeeding initiation rates. So if we look here in North America, the US has much lower rates than Canada. 73% of women initiate breastfeeding, and only 43% of them continue to 6 months. Whereas in Canada, our rates are 87 to 88% that start breastfeeding, and only 54% continue to 6 months. So there's a little bit of a difference in the US and Canada, but not as large as you would expect, given that we have much more generous maternity leave provisions than the US does. The US has no real guaranteed maternity leave at all. And if women do get it, it's around 8 weeks or so at the most. So we are doing a bit better, but probably nowhere near as good as we could as well. And just down here in the corner, if you look at like some countries like Ireland and France and the US, they have some of the lowest rates around the world. So just looking at what the recommendations are for breastfeeding, and there are some slight variations in different recommendations. So, but mostly universally, everyone recommends exclusive breastfeeding from birth to 6 months of age. And this is recommended by the World Health Organization, the AAP, or the American Academy of Pediatrics, and also the Canadian Pediatric Society. And then there's just a little bit of divergence on the follow-on. So the AAP only recommends continued breastfeeding with complementary feeding up to 12 months, whereas the World Health Organization and the Canadian Pediatric Society and a lot of other organizations recommend it for up to 2 years of age or even beyond if mothers choose to continue breastfeeding beyond 2 years of age. So when we do talk about breastfeeding, there are some different words, terminology, classifications that we use. The ideal is for exclusive breastfeeding. This is only breast milk, whether that's direct feeding at the breast, expressed breast milk, or even through a wet nurse, which is not common in North American Western countries, but is still done in some parts of the world. Babies are allowed to have vitamins, minerals, any kind of medicines, but no other liquids, solid food, or infant formula. And predominant breastfeeding is very similar, except that they allow some water, juice, ritual kind of drinks, fluids like teas or other things, but infant formula and any other liquids or food are not allowed. Partial breastfeeding is basically, as you would expect, some breast milk, they can have water or juice, and they're also probably getting infant formula or some other liquids or solid foods. And then exclusive formula feeding is when they're completely weaned off breast milk, even if they're weaned off expressed breast milk. So they're not getting any breast milk feeding. And they're usually, if they're under 6 months of age, of course, they're usually getting infant formula. And if they're older than that, they could be getting other liquids or solid foods. And so what happens with breastfeeding, we're going to, a little bit later when we look at some of the findings, it'll be important to understand the effect of the breastfeeding supply and demand cycle. So the baby starts feeding at the breast as soon as possible, right after birth, hopefully within the first hour. And that increases the removal of the milk from the breast. That causes the release of a hormone called prolactin, which stimulates the production, an increased production of breast milk. And then you have this sort of cycle that is repeat. And sometimes within the first month or two, this could be every 1 to 2 hours with some newborn babies. And so this promotes exclusive breastfeeding, and it increases the overall duration of breastfeeding. So what happens when breastfeeding is supplemented or replaced with infant formula? So the baby feels more full, sleeps longer, and then feeds less frequently. And then the milk stays in the breast. That decreases the prolactin and decreases milk production. And it also leads to a cycle where the baby may begin to prefer an artificial nipple or a teat because it's easier to take in the milk. And then they may start resisting breastfeeding. And so then starts to have breastfeeding is supplemented or continuously replaced with formula. And this can result in partial breastfeeding and often an earlier than desired cessation of breastfeeding. So just some of the health benefits. I think many of you are probably aware of some of these. In women who breastfeed, there are lower rates of breast and ovarian cancers. There is a lower rate of childhood obesity and also reduced maternal rates of type 2 diabetes later in life. For infants, there's reduced outpatient visits and hospitalizations from GI infections. In higher income countries, this is mostly reduced morbidity, but in lower income countries, this can actually be a substantial reduction in mortality from diarrheal diseases. And then there is also lower rates of upper and lower respiratory tract infections, lower rates of asthma and otitis media in kids. Breastfeeding also improves the cardiopulmonary function in children. The actual sucking at the breast improves the lung function in babies, and it results in lower rates of cardiovascular disease in women who breastfeed. And although it's still a bit controversial, there are some studies that show that breastfed babies do have a higher IQ than non-breastfed babies. So just to give you some background of where this research took place, I worked in Hong Kong at the University of Hong Kong for 18 years. I was there from 1998 to 2016, and then came back to join UBC. And so over this time, we did a lot of work on baby-friendly hospital practices and breastfeeding. So Hong Kong itself is a city of 7 million people in the South China Sea. I'm sure most of you know where it is. It's very densely populated. This is the majority of housing. This is emblematic of a lot of the housing there. In some areas, on average, there's almost 7,000 persons per square kilometer, but in some very densely populated areas, it could be over 57,000 people per square kilometer. So it's all vertical housing. But despite all this population density, in fact, Hong Kong has some very low maternal and infant mortality rates. They do have a very high quality public health network. They have public and private healthcare services available. There are 8 large public hospitals that provide obstetric services and 11 private hospitals. And this is one of the largest public hospitals, Queen Elizabeth Hospital, which has obstetric services. There are currently 3 certified or designated, I should say, baby-friendly hospitals, but that wasn't the case. They've only been designated since 2016. And there's also a network of public maternal and child health centers, MCHCs. They provide free antenatal care, postnatal care, well child care, things like vaccination and growth assessments and things like that. And in 2019, 3 of those were certified as baby friendly. And I'll go through that a little bit more and show you the timeline of the baby friendly process. So the breastfeeding rates are similar to a lot of Western countries. 85 to 87% of women initiate breastfeeding. But a lot of the previous research and some of the early work that we did showed that by 3 months, only about half of those are still breastfeeding. And at any time point, less than half who are still breastfeeding are exclusively breastfeeding. So most people are actually supplementing, or at least half of the people are supplementing with infant formula. So these rates are more similar to the US. They're a bit lower than Canada, but they're a lot higher than the UK. And just to give a little brief overview of the Baby Friendly Hospital Initiative, I think many of you would have heard about this. In 1989, WHO and UNICEF developed a set of guidelines for maternity care facilities to protect and promote and support breastfeeding. And then a few years after this, the WHO launched the Baby Friendly Hospital Initiative, which outlined minimum criteria for accreditation or designation as a baby-friendly hospital. And so there are 10 steps. They are, the hospitals must have a written breastfeeding policy that is routinely communicated to all staff. They have to train all their healthcare staff with the skills necessary to support breastfeeding and to implement the policy. They must inform all pregnant women about the benefits and management of breastfeeding. They should help mothers initiate breastfeeding within 1/2 hour of birth, show mothers how to breastfeed and maintain breastfeeding, even if they're separated from their infant. The hospital should provide no food or drink other than breast milk unless it's medically indicated. And mother and baby should be rooming in, so the baby should be staying with the mother 24 hours a day. They should encourage breastfeeding on demand. And they give no artificial teats or pacifiers or dummies or soothers or whatever you want to call them. So if formula and supplements are given, they should be given with a cup or some other way. And then once women are discharged from the maternity facilities, they should be provided information about breastfeeding support groups that they can access in the community. So I've gone through all these because we will look at these quite a bit when we look at the study findings. And I just want to highlight the first 3 here. These are more system level policies or steps, so that they can't really be assessed at an individual level. So we haven't done a lot of work with those. Step 5, show mothers how to breastfeed and maintain lactation. This one we have assessed on numerous occasions and other researchers have assessed, but unfortunately this actually seems to be an indicator of breastfeeding problems. So when mothers report that they are shown how to breastfeed, they're usually in trouble. So it's actually not good, I guess, that the only time mothers are getting support and shown how to breastfeed is when they're having problems. So we don't usually measure this in terms of the other steps. So we usually look at these 6 steps when we're looking at mothers and their exposure to baby-friendly practices. So just to give you a little timeline as to how all of this came about, I started working in Hong Kong in 1999. And so I was working with a colleague on some breastfeeding research. And, oh, sorry, my mouse is very sensitive here. There. And so the hospitals were making some, noises about trying to become baby friendly, trying to support mothers in breastfeeding. But the first big barrier that they had to overcome was that they all accepted free infant formula from the manufacturers. And so that's a big no-no for WHO. They won't even consider any kind of assessment if hospitals are accepting free formula, because it really was just sort of, I used to say it was given out like candy. You know, I had my first child in a hospital there in 2003, and they would just come along and plop, plop, plop a sort of ready to feed bottle on everyone's bedside table, whether or not they needed it. So in 2006, they did announce that they were going to start paying for infant formula. And it's really not that expensive. And of course, there is an incentive for formula companies to give it to the hospitals for free. So they were planning to implement it in 2007 or 2008, but it did get delayed several times because of lobbying and marketing sort of tactics of the formula companies. So finally, in 2010, they implemented the formula, paying for formula policy, and they started paying attention to baby-friendly practices in the hospitals. Then in 2013, the government announced that all public hospitals had a mandate to become baby-friendly within 10 years. And that was quite a short time frame, and actually they're very close to achieving that goal. In 2016, the first public hospital was baby-friendly designated. And then in 2018, a second one was designated. In 2019, the third one, and then also 3 of the maternal and child health centers were designated baby-friendly. And then now the status is in 2020 that there's 5 remaining public hospitals and 1 private hospital have signed the commitment, the letter of commitment to become baby-friendly. And actually a few of them are in various stages, like stage 1 or stage 2. So they are all on the road now to becoming baby-friendly. So this actually provided a good opportunity for us to do a lot of research, but it didn't all come, it wasn't like we thought right away, oh, we have to like study this for the next 10 or 15 years. It kind of evolved over that time. So once they first started talking about the formula policy, we knew that there had been very few studies which had really looked at some of these, the implementation and the effect of these policies. So we wanted to just study that one first. So this was kind of a naturally occurring experiment. And what it would end up is several naturally occurring experiments over the next 15 years or 10 years. We wanted to look at the impact of the baby-friendly implementation in public hospitals on what happens to baby-friendly practices or hospital practices, and then also what happens to breastfeeding. And for the most part, we looked at it up to 1 year with one exception. So we did 3 fairly large cohort studies. We call them cohort 1, 2, and 3, or the first one was done in 2006 and 2007. This was pre-implementation of the paying for formula policy. So we recruited 1,400 mothers, and we followed them up for 1 year. And then the second cohort was done in 2012 with 1,454, I think that's a typo. I think it's actually 1,300 and something. That's what I get for copying and pasting. And we also followed them up for 1 year. And then cohort 3 was done in 2017, 2018 with over 1,200 mothers. And those we followed up for 6 months, because in our first 2 cohorts, after 6 months, there's the law of diminishing returns that most women have stopped breastfeeding by then. So for the last cohort, we just followed them for 6 months. And we recruited from 4 out of the 8 public hospitals that have obstetric services. And as I said, we followed up the first 2 for a year and then the last one for 6 months. And so just to situate you in that previous timeline, our first one was here after they announced the formula policy, but before they implemented it. And then we collected the second cohort to sort of look at some of the outcomes related to that. And then once we had our first hospital designated as baby friendly, we did the third cohort to look at some of the impact of the implementation of the baby friendly hospitals. So the third one sort of happened around here. Some of it was after the second hospital became designated. So what we were looking at, for all of the studies, we had the same core objectives, but we also had some other things that we were looking at related. We looked at some things around breast milk expression practices and other things, but we also wanted to assess the core baby-friendly practices. So we wanted to assess the effect of the BFHI implementation in public hospitals on what happened in the hospitals and how the mothers were being cared for in terms of the practices in the hospital, and also the breastfeeding outcomes. So we looked at the changes in some of the rates of the practices. The in-hospital formula supplementation rates we were very interested in, because almost all babies, breastfed babies, even healthy babies, were getting formula. And then we wanted to look at the overall impact of baby-friendly practices on the duration of any and exclusive breastfeeding. And then we wanted to look over time to see what were the changes in breastfeeding duration and exclusivity. So just our selection criteria for all three of the studies was they were intending to breastfeed. Singleton pregnancy, they had to speak the local language, which is Cantonese, and they had to be Hong Kong residents for more than 1 year. And the reason for that mostly is because a lot of mainland Chinese women do come to give birth in Hong Kong, but then go back to China afterwards, or they're back and forth a lot, and they're hard to follow up if they're going back and forth across the border. And then we were looking for healthy mothers and infants, so we didn't want any serious medical or obstetrical complications. The infant had to be full term, so at least 37 gestational weeks, healthy at birth, birth weight of greater than 2,500 grams, no severe congenital or medical anomalies, and they had to be in the regular ward or in the SCBU, which is the special care baby unit, for less than 48 hours. If they were admitted to the NICU or stayed more than 48 hours in the special care unit, they weren't eligible. Or for some of them that were already recruited, then we didn't continue. We discontinued them in the study. So we did a lot of data collection. We did maternal and family demographic data. We have all the birth and infant, maternal and infant birth data, and we have infant feeding data in the hospital. And then at the telephone follow-up, we did infant feeding data. We used the WHO 24-hour recall method, which just asked them in the last 24 hours, how many times have you breastfed? How many infant formula feeds have you given? And how many expressed breast milk or other types of feeds you have given? And then once they had stopped breastfeeding, we ascertained their final, the weeks of any and the weeks of exclusive breastfeeding. So we compared the exposure to baby-friendly hospital practices across the 3 time periods, and we examined the effect of that on breastfeeding duration, and we compared the participants who were still breastfeeding across the 3 time periods. And we used some different statistical methods like logistic regression, Cox proportional hazards model, and I'll show you some of the findings from those. So just a summary of our findings. So this was just the flow diagram. We recruited 1,417, but we had some that were excluded after recruitment in all 3 studies for not meeting the, or subsequently meeting an exclusion criteria. We did lose a substantial number, not a substantial number, small number after hospital. They just dropped off the radar and we could not contact them again. But you'll look and see that we had at least partial follow-up on well over 90% of all 3 of the cohorts. Even the partial follow-up, we may have gotten them at 3 months, for instance, and then lost them, or we might not have gotten them at 1 month, and then we might have managed to catch them at 6 months, for instance. So we had high follow-up rates. So the characteristics of the participants were, they remained relatively stable, even given that it was about a 13-year period. The maternal age just crept up a little bit. The one big difference was women were more educated in our later cohorts. They had higher education levels. The parities kind of stayed the same. Intention to exclusively breastfeed varied. It changed, but it didn't really have a specific pattern to it. And then it was a few more in the last cohort that had previous breastfeeding experience. And the return to work didn't change much in the last 2 cohorts. And in Hong Kong, the return to work is very similar to the US. They get 8 weeks, 10 weeks of maternity leave, but 2 have to be before they give birth, and then 8 weeks. And so most women, about 75 to 80%, do go back to work. So just to look at some basic comparisons of our practices, if you remember the 6 steps that these were the ones that we were interested in looking at: initiating breastfeeding we measure 1 hour. WHO says a half an hour, but it's actually in most modern obstetrics units, that's sometimes a challenge to get half an hour. So we measured within the first hour, no food or drink. So that means no formula supplementation, whether they were rooming in, breastfeeding on demand, no artificial teats or pacifiers, and then whether they were given information on breastfeeding support. And this one we measured at 1 month. The rest, all of these were measured in the hospital. And this one we asked the mothers at 1 month during their follow-up if they have been given this information when they were discharged from the hospital. So we were very happy to see that for the most part, so this is the 2006 cohort, the 2011, and then the 2017 cohort. For the most part, the practices all increased. So this means that more mothers were exposed to these practices over the 3 different cohorts. This one went up and then came down again. There is a bit of a bright side to that for women undergoing an operative birth, which I'll show you in a few minutes. But the one that really struck me was in 2006, over 80% of healthy full-term breastfeeding babies, not formula feeding babies, breastfeeding babies, got formula in the hospital. And in the 3rd cohort, 17% were exclusively breastfed. So that means over 80% received formula. And then at the last cohort, over 60% of them left the hospital exclusively breastfeeding. So there's been a big change in that. With rooming in, the first 2 cohorts were very similar, but 2/3 of mothers were rooming in. And for some of the data collection, because we use the same 4 hospitals, I know that in these 2, we had 1 hospital that did not room in the whole time we were collecting data. And then now, because they're on the pathway to baby friendly, they've had to go back to rooming in. So a lot of this was just 1 hospital changed. A little bit of change in breastfeeding on demand. Again, same thing with the formula, a big change. So 95% of babies that do get a supplement do not get it through a bottle. They get it through a cup or some other form. And in the regular nursery, and pacifiers themselves are not widely used in Hong Kong, and they're never usually given just a pacifier in the hospital. If they get an artificial teat, it's usually because they're given formula with an artificial teat. And then almost 100% of them are provided information about the community support. So we were very impressed with the increase in the some of these. And I'm going to specifically highlight these 3 here, because there's been some more significant improvements, which we'll look at. So the first hour after birth, initiating breastfeeding. So as I've just said, what we found actually is that the median time to the first breastfeed, it decreased in 2011, but then it increased again. So it went from 3 hours down to 1.5 hours, back up to 2 hours. So 50% of women are not, achieving the goal of breastfeeding within the first hour. So, but there is some evidence that prolonged delayed initiation is improving. And you can see that the median duration of first breastfeeding among mothers who had a cesarean improved substantially. This is all participants here. But if we look at mothers who had a cesarean, in 2006, 2007, the median was 24 hours. So really it was uncommon for breastfeeding mothers who had a cesarean to actually initiate breastfeeding within the first 24 hours. They were often told to rest, to take care of themselves, and the baby would be given formula, and they could start breastfeeding when they were feeling better. In 2011, this was down to 2.6 hours. And then in 2017, it's down to 2.6 hours. So sorry, from 4 to 2.6. So there's been substantial improvement. And you can see here from the graph that there is, there's like the first cohort was just really kind of atrocious for women who had a cesarean section. So we're very pleased to see that there's some improvement in that. And then this is just looking at, this is again for mothers who underwent a cesarean section, looking at when, how long it takes them to have the first breastfeed. So within the first hour, in 2006, it was only 2.7%. That went up to 10% in 2011 and up to 16% in 2017. Still not great, still a lot of area to be improved, but I was, a bit at least relieved to see this, that in the first cohort, only 60% of women with a cesarean actually breastfed in the first 24 hours, whereas that was well over 90% in the second cohort. So the other one that we looked at was no food or drink other than breast milk, or we kind of often just talk about supplementation, like how many babies are getting supplemented with formula. So in the first cohort, babies were getting an average of 2.7 supplements in the first 24 hours. So if you say 8 or 10 feeds in 24 hours, at least 3 of them were formula. In 2011, that dropped to just over 1, and now in 2017, it's dropped to less than 1. And that's the average. And we also computed the proportion of breastfeeding, excuse me. So we looked at the total number of feeds in the first 24 hours and looked at what % of them were breast milk or breastfeeds. So it was only about 2/3 in 2006. Now it's 84% in 2011, and then it's almost 90% in the last cohort. We did find, though, that again, cesarean birth contributes a lot to formula supplementation. In the first cohort, almost all babies who had a cesarean got formula. In the second cohort, it was 3/4, and in the last cohort, it was half. So it's improved quite a lot. It's still got a ways to go, but it improved quite a bit. But the formula itself also, we wanted to look at, it's not all hospital driven. There are some maternal characteristics. So we know that mothers have some voice in this as well. So if they really intended to exclusively breastfeed, they were about 58% less likely to get formula or have their baby get formula. If they had previous experience, they were 33% less likely. And if they had higher maternal education, they were also about 35% less likely. So it's not just driven by hospital practices. There is some maternal preferences and maternal choice in that as well. Just checking my time here. So the last one that we looked at was artificial teats and pacifiers. And this showed quite a bit of success as well. Now, I had some data from 2000 from a very small study we did back in 2000. And so you can see this is people getting a bottle, like how the supplements were given. And you can see in the last cohort, it's only 15% given in the bottle, and most of them, as recommended by WHO, are given in a cup. So over 80% of them were given in the cup. And there's some discrepancies between those numbers because there are a few percent that are given through a syringe or a spoon or some other, but the majority are now given in a cup. So they're cup fed.
Marie, just because you mentioned the time a second ago, maybe about like 5-10 minutes, and that will give enough time for
Okay.
Dr. Vora.
I think I should be finished up, and I'll just
Okay,
push it along a little bit.
perfect. Thank you.
So then the other thing we wanted to look at, because we know you can look at the individual practices, but there's also the cumulative exposure. So how many of those 6 practices are mothers exposed to? And so we looked again. So in the first cohort, almost like 7% of them were not exposed to any or maybe just one practice. And then, so what we can see is that the low numbers, which is bad, like we want mothers exposed to all 6 if possible. Those, so that did go up, like the mothers who were exposed to 5 practices, 5 out of the 6 is more than half of them in the third cohort, whereas in the first cohort, it's mostly the low number. So 1, 2, 3 practices. So we were looking at the cumulative number as well, and that improves. So more mothers are being exposed to more baby-friendly hospital steps. And so I just have a couple slides about this on the effect on breastfeeding. So formula supplementation is one of the strongest predictors of early weaning, and we discussed the reason for that early on. And so it's almost doubles the risk of early weaning if they have formula in the first 24 hours. There is a dose response effect of formula supplementation. So the more formula they get early on, the less likely they are to breastfeed, the shorter their breastfeeding duration is. And there's also no real safe threshold. Even one bottle of formula can affect breastfeeding practices. The median duration of breastfeeding is 3 times higher among mothers who exclusively breastfeed during the hospital stay. And you can see here, this is exclusive breastfeeding. So they have a median duration of 25 weeks. Even a small amount, like less than 20% of formula, reduces that by more than half. And then higher amounts of formula, like less than 80% breastfeeding, it goes down to 8 weeks. So we know that formula is very detrimental. And even high partial breastfeeding increases the risk of weaning by about 55%. And then low to medium increases it by 90%. And then looking at the steps, we looked at them all individually. And so again, within the adjusted analysis, the 2 that are most important are the breastfeeding initiation within the first hour, and then only breast milk given or no formula supplementation. And so the risk reduction for this is around 30%. So if they're exclusively breastfed, they're 30% less likely to wean early. And with early breastfeeding, it's about 13% less likely. But the biggest effect comes when you combine them, when you look at that cumulative exposure. So you can see here, can everyone see the diagram on this side? Because in my screen, all the pictures are covering up, all the photos are covering up. So you can see here that this is the lowest number of baby-friendly steps, 0 to 1. This is 2 to 3, I think 3 to 5, and then 6 here. So mothers who have 6 exposed to all 6 baby-friendly steps are much more likely to breastfeed for a lot longer. There's kind of what we say an inverse graded association. So the more steps you're exposed to, the lower your risk is for stopping breastfeeding. And again, the median duration of breastfeeding is 4 to 5 times higher among mothers who are exposed to all 6 baby-friendly hospital steps. And each step itself reduces the risk by 8%. And you can see this is the data here, which is just shown in the graph. So the risk is about double if you have, not quite double, but about 3/4 higher if you have 0 to 1 steps compared with someone who has experiences all 6 steps. So just a couple of slides here to show. So this is the breastfeeding continuation rates over the 12 years of the data. So in the first cohort, only 70% were still breastfeeding at 4 weeks, and now it's over 90%. And then it goes, you can see, gradual decrease over time in the breastfeeding rates, but there are much more, you can see there's much more improvement after hospitals start actually becoming baby friendly, that you can see there's a much higher improvement. And unfortunately for the 3rd cohort, we didn't measure past 6 months. And then this shows you the graph where the median duration is more than 6 months in the 3rd cohort compared to 8 weeks and 12 weeks in the first 2 cohorts. So it did increase substantially over the 3 time periods. And it increased from 8 to more than 26 weeks. So just some conclusions. There has been substantial improvement in all of the baby-friendly hospital practices during the stages of implementation. So in the final cohort, 1 hospital was baby-friendly, 1 was almost baby-friendly, and the other 2 were in the early stages of becoming baby-friendly. The proportion of exclusive breastfeeding increased quite a bit from 17.7 to 65%, which was a big increase. The other thing is exposure to baby-friendly practices has a dose response effect. So the more mothers are exposed to, the better it is. Each extra step decreases their risk by 8%. And the breastfeeding rates in cohort 3 were much longer than in the first cohort. Having said that, as you can see from some of the practices, there's a lot of work that still needs to be done. Until it's 95% exclusive breastfeeding rates, there's still more work to be done. But by just some sort of informal estimates, from 2006 to 2018, about 8,000 to 12,000 infants per year are breastfed to 6 months annually. So an extra 8,000 to 12,000 from the first cohort to the 3rd cohort. Public hospital practice are much more baby friendly. There is earlier initiation, a lot less formula, and artificial teats are not being used anymore. Sorry, and that one just says what I said before. So early supplementation is strongly associated with early weaning. And the provision of formula to hospitals by infant formula manufacturers has been a very effective marketing strategy for their products. When they give free formula, it's not that they're being charitable and altruistic. They know it's like any sample you get at the supermarket. If you try it and you like it, and you'll probably buy more. And with breastfeeding, once you try formula several times, you're almost forced to keep using it. So it's a very good marketing strategy. And there's also that endorsement. When hospitals provide infant formula, there's some sort of implied endorsement by the hospital and the healthcare provider, both for the formula itself, but also for the brand that the hospital is providing. And when the institutions are paying for that, there's less incentive to provide it unless it's medically necessary. The one important thing I think I'd like to stress is that the baby-friendly designation itself is not a zero-sum game. I hear a lot of discussion around here that, oh, we can't get there, so we're not even going to try. So the designation itself is the end point, but the process is actually quite important. And the process of making hospitals more baby-friendly is just as important as actually reaching the end goal. I know from being in Hong Kong over all that time, there was a huge benefit of all the increased awareness of why baby-friendly practices are beneficial, even in the public, because there was a lot of discussions about things in the newspapers and in the popular press, the consequences of not adhering to baby-friendly practices, and the potential harms of early formula supplementation. So this whole process created a large amount of discussion and public awareness about the needs for improvements. more breastfeeding support. And at the same time, Hong Kong also introduced their own code of marketing of breast milk substitutes to align with WHO. So there was a lot of awareness caused by this. And even if it's the mothers themselves are coming into the hospital and forcing the change on the hospital, you know, demanding better practices, that in itself is an accomplishment as well. So just a few strengths that we had 3 large cohorts. We had long-term follow-up. We did have very low loss to follow-up or dropout rates. There were large gaps between our data collection points. It could be that all these things would have happened irrespective of what was going on. The breastfeeding data was self-reported. You know, we telephoned mothers, but there's lots of studies which show women are very good reporters of that kind of data. They are non-population based samples. So as cohorts, they're just, you know, volunteer. Again, because of these gaps and things, we can't determine cause and effect. And we still have a lot of work to do actually on the 3rd cohort, because what our goal with the 3rd cohort, because we had 4 hospitals in different stages of designation, that we want to actually look at the individual hospital level. What was the before and after practices in the individual hospital? Just some acknowledgement of our research funding, our grant provider in Hong Kong, the Health and Medical Research Fund, Hong Kong U, and then more different funding from Hong Kong U.
Well,
And
thank you. Oh,
some,
sorry.
no, sorry, just some of our team members. A lot of students were supported with some of this work as well, and some relevant publications. And that's it.
Thank you so much, Marie. That is so informative. You're so clear and concise with everything. And it's inspiring to see how much it made such a big impact. Just so everybody knows, we're going to go now to Dr. Vora. So thank you so much, Dr. Tard. That was awesome. We're going to go to Dr. Vora, who's going to give some of her thoughts on this. And while she is doing that, if you want to write some questions in the chat box, you can. We're going to go probably about 10 minutes over. So 9:10 here and everywhere else in your country, so about 10 minutes over. And then, yeah, so let's start. Dr. Vora, what are your thoughts?
Thank you so much. And that was excellent presentation, Marie. And research. Can you hear me?
Yes.
Yeah. So really good presentation and very good research. And it was interesting how you covered everything, not just hospital practices, but also you talked a little bit about maternal background and how public awareness, you know, kind of made a difference to how the practices changed. Baby Friendly Hospital has been a very good initiative by international developmental agencies. And in India also, we are struggling to ensure that this happens. And to me, it seems that it's not resource intensive, but it is process intensive, that you need to make sure that certain things happen with each and every mother, and everyone follows what needs to be followed. So I guess there are issues related to that, why a lot of Indian hospitals are also reluctant to, you know, take up something like this. But it was, I myself have some questions, but I think I'll keep them for later. But I just wanted to kind of connect this to a community-based study that we had done in India, which was in urban area, rural area, and tribal areas of Gujarat state, from where I am. And what we found that in urban slums, only 35% of babies were breastfed within 1 hour. So despite the Indian tradition and, you know, culturally, and you would think that if you are poor, you won't have access to formula milk and etc. etc. Despite that, the proportion of mothers who are breastfeeding within 1 hour is pretty low. And I don't know if you looked at this, but we also asked them about colostrum, whether colostrum is given or not, because India traditionally they avoid it, or they you know, discard it. So about 75% children had it. So still there were like quarter of percentage of children who did not have colostrum. And similar to what you reported, even in the poor mothers, we found that about 77% of children were given something. They were not exclusively breastfed for 6 months. They were given something in between. So these numbers are higher, and I think baby friendly hospital initiative is kind of a way to start this whole process, because as you said that initially if you give formula feed, the chances of longer breastfeeding are much less and exclusive breastfeeding are much less, and I think that goes beyond cultural barriers and everything. So uh, I guess we need to build that up, and your research will actually provide a lot of evidence for this baby friendly hospital initiative. So thank you so much. And because the time is less, I will stop here. But I myself have a lot of questions. So I am going to. So there's a question, Emily. I take it now, or you will kind of.
Yeah, I would say, why don't you start us off with questions? And so feel free to ask, your top questions for Dr. Tarrant.
Yeah, I actually, what you said last, I was going to suggest that because your hospitals seem to be in different stages of baby friendly hospital
Mm-hmm.
initiative. So it would actually help to, see by each hospital, because I felt a lot of your percentage were pushed up or pushed down by a single hospital because what was happening or whatever stage it was in. So that was something. And the other thing I wanted to ask you, or maybe you can take into consideration, is what happens after she goes home, because you said that 75 to 80% go back work. So workplace environment, whether they have a crash there, they are allowed to go back home, or I don't know, those kind of things would have impact on the duration of breastfeeding. So maybe
Mm-hmm.
those things can be. Thank you.
Yes. Sorry, what was your first? The first. Oh,
Yeah.
yes, about the different hospitals. Yes. So yes. So what we wanted to do from the second cohort to the third cohort is match the hospitals and compare. So we had one hospital that was designated, fully designated by the time we did the second data collection. We had one hospital that became designated during our data collection. We had one hospital that only had a certificate of intent, and one hospital who at that point in time wasn't even on the pathway. So we want to then match hospital to hospital and look at the changes in the practices. So we just haven't, that hasn't, I tried to look at some of that, but it's too rushed for data analysis to do it for the presentation. I don't want to give sort of false data. So that's one of the things we
Yeah.
want to look at. And the maternity leave and the home support and thing is another. I mean, and in other areas, we've also done some randomized trials of different support interventions, because we know when the mothers go home, in the Chinese culture, the mother-in-law is very influential and likes formula, likes all of those kind of things. And so we know that there's a lot of pressure on them, and they go back to work so early. They'll go back around 8 to 10 weeks. So, and they work long hours. Hong Kong's a very work-centric place. The mothers work long hours, and so they can go and get support from the maternal and child health centers, but of course they also have the doing the month, the sitting in for the 30 days after childbirth, so they don't like to go out. And as some of us were talking about before, COVID is just adding to that as well, right? That they don't want to go out and get support.
Yeah.
Did you have one more question, Dr. Vora, or should I go to some of the other ones? Oh, I think there we go.
No, I think I'll give time for others. I do have
Feel
others.
free,
Okay, yeah.
feel free to write them in the box, and if we get time, we'll answer them as well. Okay, so there was one question that I wanted actually just to start off
Sure.
with, because I think it's a very practical one, and that's for Dr. Tarrant, and that is, how can we be part of the initiative? Any available data from Africa and KSA?
I don't have any data from Africa. I know, but I think Africa in some ways may be very similar to China in that you have all these rural communities where women are breastfeeding more, and then you have these urbanized areas where women are going to work, and the breastfeeding rates are dropping off because of workforce and those sorts of things. So I think part of I think what led it in Hong Kong was that there was um, public pressure to do this, to make hospitals more baby friendly, because mothers were, reporting sort of things that happened to them, and so there was some public pressure. There was also health professionals, although there was a group that were reluctant because they thought it was going to be a lot more work, and there was another group that was leading the charge. So the big thing is Hong Kong has a baby friendly group, so you can get together and form, like professionals forming a baby-friendly group that is interested in promoting baby-friendly. And I think, again, if you're in a healthcare facility, designation is great. Yes, it does a lot for your practices, but just becoming more baby-friendly is achievable as well. And you can start with one thing. Start with early initiation of breastfeeding. Try to get all mothers breastfeeding within the first hour or so after birth. Start with one thing.
Perfect. We have a question from Ava, which was, hi, Dr. Tarrant, wondering what the model of maternity care is in Hong Kong. Is it exclusively physician-led or interprofessional groups, including midwives?
Mostly midwives. In the public hospitals, for all normal, I mean, there's obviously obstetricians and all that thing, but they usually do the more complicated births. And so it's a midwife-led model, generally speaking. In the larger referral, like we have 2 teaching hospitals, which have the more high-risk cases and things like that. I mean, they still have a midwifery-led model, but of course there's a lot more high-risk cases that are attended to by OBGYN, but generally it's midwives, and in the maternal and child health centers, it's also midwives leading the care there. So it is a very nurse midwife centric model. Even when you're antenatal care, you only see the obstetrician once every trimester, unless you have some reason. Otherwise, it's all led by midwives.
Oh, that's fabulous. We need to get more of that here.
Mm-hmm.
Dr. Schroff writes, it seems that there's a rapid drop in breastfeeding rates in Hong Kong. What are the main reasons for this? And what would you recommend as a way of reversing this so that more women would breastfeed for a longer time?
I think probably the 2 main things, returning to work is a big issue, right? Most workplaces most 75 to 80% of women do go back to work. They go back full time. Part-time work is not a big option. I wouldn't say it's not done, but most people are going back to work full time, 45 hours a week, 45 to 50 hours, long commutes, those kind of things. So that's certainly, the government has just extended maternity leave to 14 weeks, which is like, yay, an extra couple of weeks. So that will be helpful, because even some work that one of my PhD students did, looking at even those extra 2 to 3 weeks of maternity leave, makes a difference as well. Because if you can get over to 4 months or something like that, you're much more established, and so maternity leave is a big thing. And I think sending babies home exclusively breastfed already, because it's a cycle. What happens is they get on formula in the hospital, they go home, they're having trouble breastfeeding, they don't get enough support, and they're going back to work in 8 weeks, which they think, well, the baby's going to have to go on formula again when I go back to work, or so they just give up and give formula, So I think the 2 of those interplay quite a bit.
Yeah, and absolutely. And once you're in at work, I always say that the breast never performs for the pump like it does for the actual baby. So that is just a tank.
Yeah.
I do actually have a question. There was a question for Dr. Vora, and that was, hi, Dr. Vora, do you know what factors are leading to such low breastfeeding outcomes in urban areas in India?
Yeah, I think some of the factors are similar to what Marie talked about. Are more women working, a lot of women going back to work early, the support system that they have at home, and this whole idea that if I have to go back to work within a month or 6 weeks, why bother starting breastfeeding when, as it is, my kid is going to go to formula feeding? The other thing which is happening in a lot of developing country, I'm not sure about Africa, but in Asia and especially in India, is that formula feeding is seen as something which is modernization. So if I can afford formula, or if I can, if I'm giving bottle feeding, then that makes me a modern mother or somebody who can afford certain kind of things. So there are a lot of factors which are playing their role in that. But I think lack of support system and more working mothers are the main factors which are leading to such low proportion of breastfeeding and initiation of breastfeeding.
Yes, the status bottle feeding. Um, it's the same thing with cesarean rates as well.
Yeah, absolutely. Yeah,
The too posh to push was the
yeah,
term that is used
yeah.
in the Lower Mainland Canada. Um, so we have a question. I think Farah, if you can send me that question, that would be great because I'm not seeing it for some reason in my. And then while we're waiting for that one, um, I will just ask, there was another question, which was, we tend to be, in this wonderful bubble where we are all, have like-minded and we're really big advocates for promoting breastfeeding. So it seems so obvious. Everything you're saying just makes so much sense. So where are you finding the resistance from the hospitals to implement this? Is it mostly a financial thing? Is it staffing? Is it just adding one more project? Where are you finding you're getting the most resistance?
I think it's both the financial commitment, because you do need to provide more breastfeeding support, and really have dedicated lactation consultants to do breastfeeding support. Um, you still have a lot of, even among midwives, you still have some resistance to, oh, one bottle is not gonna hurt, and oh, the mother. And the other thing in the Chinese culture is the maternal rest is so important, postpartum maternal rest, that, oh, let's just give the baby one bottle. You can sleep, you can rest, you can do that. So there's a lot of different, I think, a lot of different push and pull factors. The public hospitals as well in Hong Kong, the nurses even in the obstetric units, they are so busy. I mean, they do have a huge workload, and that's why I think, as I said earlier, that one indicator that where if you show mothers, if when mothers report that they've been shown how to breastfeed, it shows that they have lower rates of breastfeeding, because that means they're already in trouble and they're only getting support when they're really, really in trouble, as opposed to everybody getting that sort of universal support. So I think it's a staffing, it's a time issue, it's a resource issue.
Absolutely. Our final question of the evening and morning is going to be from Dr. Helen Bertrand. I don't know if you're French or Bertrand. And the question is, did you check the use of ER and other health issues in correlation with breastfeeding duration? How difficult would that be?
We did a study back in 2010, I think, a separate study from this. We had another very large childbirth cohort, and we looked at it early. So we looked at them like within the first 18 months. And then we also looked long-term, like we went back and looked at them when they were 8 and 9 years of age. So what we found is that definitely early on, they had lower rates of outpatient visits for most of the infectious diseases. They had lower rates of hospital admissions. And they had, just in general, lower hospital and lower doctor utilization. At the older age, we didn't notice a difference. The main benefit was in that first 18 months, and even in the first 6 to 12 months. But there definitely, there was and of course, like everything, the more exclusive, the greater the benefit was. So we did do a large study, because in Hong Kong is great. They have public hospitals and they have an ID system, so you can easily link birth records to public hospitals. So we did look at that. Thank you. Great question.
Oh, this is been, I feel like we could just keep talking about this for like the next 3 hours and then just open everyone's mic and just keep on going. So I am so sad to see this webinar end today. Dr. Tarrant and Dr. Vore, you guys have been phenomenal. And I feel like a lot of us are extremely excited and inspired to really push this in all corners of the world. So I think we need to get you back on, and we need to do a follow-up and we need to really keep the communication going, because I think that that this week, I mean, I can say in Canada, we need more of this, absolutely, here. And it sounds like in India, we absolutely need some, and we've got interest from Africa. So
and
yeah.
BC only has one baby-friendly hospital, you know,
BC Women's Hospital.
Yeah.
And I know that because whenever I go to someone else's hospital, or like another hospital outside, I am shocked at what I see. Baby, you know, women with, yeah, anyway.
Yeah.
It's been fabulous.
Well, thank you very much for inviting me.
If anyone is interested for more information, please contact us.
Yes.
Email my
Email
cares.
me.
You can contact Dr. Tarrant. Absolutely. And then yes, maybe we can see what else can grow from this. So